Hello students, let's continue our lecture on angina pectoris. Calcium channel blocker. Now calcium channel blocker are of two types, dihydropyridines and non-dihydropyridines. Dihydropyridines, whereas non-dihydropyridines are used as class 4 antiarrhythmic drug. Example of dihydropyridines: amlodipine, nifedipine, nicardipine, clevidipine. So class 4 antiarrhythmic drugs, which are calcium channel blockers. Calcium channel blockers are of two types, dihydropyridines and non-dihydropyridines. Non-dihydropyridines are used as class 4 antiarrhythmic drug, whereas dihydropyridines, they are not used as antiarrhythmic drug because they worsen arrhythmia. Examples include amlodipine, nifedipine, nicardipine and clevidipine. Dihydropyridines, cause peripheral vasodilation. Vasodilation in case of dihydropyridines is more potent as compared to vasodilation seen in case of non-dihydropyridines. And due to this peripheral vasodilation, there is decrease in blood pressure. This decrease in blood pressure causes compensatory increase in sympathetic discharge. And that causes reflex tachycardia. So this reflex tachycardia causes heart rate to increase. Another important point regarding dihydropyridines. Dihydropyridines mainly block calcium channel on smooth muscle of blood vessel. So they are mainly used in treatment of hypertension. So we have studied here dihydropyridines. They cause peripheral vasodilation, and this vasodilation is more potent as compared to vasodilation seen in case of non-dihydropyridines. So this peripheral vasodilation causes decrease in blood pressure, and that causes compensatory increase in sympathetic discharge. That results in reflex tachycardia due to reflex tachycardia, heart rate increases. Now another important point regarding dihydropyridines. Dihydropyridines mainly block calcium channel on smooth muscle of blood vessel. So they are more selective for smooth muscle of blood vessel. So they are mainly used in treatment of hypertension. Non-dihydropyridines are class 4 antiarrhythmic. Examples of non-dihydropyridines: verapamil, diltiazem, verapamil and diltiazem are selective for cell of SA node and cell of AV node. Verapamil and diltiazem are also selective for atrial cell and ventricular cell. So non-dihydropyridines, they are class 4 antiarrhythmic drug. Examples are verapamil, diltiazem. They are selective for cell of SA node, cell of AV node, and they are also selective for atrial cell and ventricular cell. Non-dihydropyridines, calcium channel blocker, example verapamil and diltiazem, have cardiac depressant effect. That is, they cause decrease in heart rate, decrease in conduction, and decrease in contraction of heart. So decrease in heart rate is negative chronotropy, decrease in conduction, that is negative dromotropy, and decrease contraction, that is negative inotropy, due to cardiac depressant effect of verapamil and diltiazem. Verapamil and diltiazem also cause peripheral vasodilation. So peripheral vasodilation results in decrease in blood pressure. Due to that, there is compensatory increase in sympathetic discharge that results in reflex tachycardia, so heart rate increases. So heart rate is increased due to compensatory increase in sympathetic discharge, and here heart rate is decreased due to cardiac depressant effect. So what will be the net effect? Net effect, that is heart rate is normal. Net effect, that is heart rate is normal. Why? Because reflex sympathetic stimulation due to vasodilation partly contracts the direct bradycardia producing action. So what is the net effect of verapamil and diltiazem? Normal heart rate, vasodilation, and AV block. Non-dihydropyridines, calcium channel blocker like verapamil and diltiazem, due to combined effect of cardiac depressant effect and peripheral vasodilatation effect, the net effect of verapamil and diltiazem on heart rate is normal or decreased heart rate. And normal or decreased heart rate result in no increase in oxygen demand. The other effect of verapamil and diltiazem is vasodilation, resulting in increase in coronary blood flow. Third effect is atrioventricular block. So verapamil and diltiazem are used in stable angina as monotherapy due to its effect, that is normal or decreased heart rate and vasodilation. That is helpful in angina pectoris, stable angina, because there is no increase in oxygen demand due to normal or decreased heart rate. Due to vasodilation, there is increase in coronary blood flow. So verapamil and diltiazem are used in stable angina as monotherapy. Verapamil and diltiazem cause direct bradycardia. So never add these drugs like verapamil and diltiazem with beta blocker. And if added, they can cause severe bradycardia and even complete heart block may result. We have already studied prophylaxis or long-term management of stable angina. Verapamil or diltiazem is given in stable angina for prophylaxis or long-term management. Verapamil or diltiazem is given in stable angina if beta blockers are contraindicated, like in patients of bronchial asthma, diabetes mellitus, and peripheral vascular disease. Dihydropyridines, in case of stable angina, cause vasodilation. Dihydropyridines are more potent vasodilator. Due to vasodilatation caused by dihydropyridines, there is decrease in blood pressure, and that causes increase in sympathetic discharge. So heart rate increases, and that causes reflex tachycardia. Due to much more increase in reflex tachycardia, there is increased oxygen demand of cardiac cells, and that worsens angina pectoris. Therefore, dihydropyridines are combined with beta blocker in case of stable angina, as beta blockers prevent a rise in heart rate. So example of this combination is nifedipine sustained release with beta blocker. Prophylaxis or long-term management of virulent angina, which in case of prophylaxis or long-term management of virulent angina, dihydropyridines are given. Examples of dihydropyridines which are used in virulent angina prophylaxis are amlodipine and nifedipine sustained release. Amlodipine is longest acting dihydropyridine. Coronary vasodilator effect of nifedipine is much more, and hence it is useful in virulent angina. Side effects of verapamil. Verapamil result in vasodilation that result in hypotension as side effect. Vasodilation of meningeal arteries result in headache. Precapillary vasodilation at ankle joint result in ankle edema. So due to precapillary dilation at ankle joint, more fluid to leak out of blood vessels into the tissue. This fluid will collect around the ankle and result in ankle edema. Other side effects of verapamil: constipation due to relaxation of intestinal smooth muscle. Constipation due to relaxation of intestinal smooth muscle, and decreased heart rate, that is bradycardia. Verapamil blocks cardiac calcium channel. So verapamil is more cardioselective. Verapamil has stronger action on heart than vascular muscle. Diltiazem blocks cardiac calcium channel as well as vascular calcium channel. So diltiazem is less cardioselective than verapamil, but diltiazem is more cardioselective than dihydropyridine calcium channel blocker. So more cardioselective is verapamil and less cardioselective is diltiazem. Diltiazem. Diltiazem is similar to verapamil except it decreases myocardial contractility to a lesser extent than verapamil. Adverse effect, contraindication and drug interaction are the same except constipation. That means diltiazem does not cause constipation and all the other adverse effects, contraindication and drug interaction are the same as compared to verapamil. Dihydropyridines. Dihydropyridines cause peripheral vasodilation. Vasodilation in case of dihydropyridines is more potent as compared to vasodilation seen in case of non-dihydropyridines. And due to this peripheral vasodilation, there is decrease in blood pressure. This decrease in blood pressure causes compensatory increase in sympathetic discharge. And that causes reflex tachycardia. So this reflex tachycardia causes heart rate to increase. Another important point regarding dihydropyridines. Dihydropyridines mainly block calcium channel on smooth muscle of blood vessel. So they are mainly used in treatment of hypertension. So we have studied here dihydropyridines. They cause peripheral vasodilation, and this vasodilation is more potent as compared to vasodilation seen in case of non-dihydropyridines. So this peripheral vasodilation causes decrease in blood pressure, and that causes compensatory increase in sympathetic discharge. That results in reflex tachycardia, and during reflex tachycardia, heart rate increases. Another important point regarding dihydropyridines. Dihydropyridines mainly block calcium channel on smooth muscle of blood vessel. So they are more selective for smooth muscle of blood vessel. So they are mainly used in treatment of hypertension. Nifedipine. Nifedipine is example of dihydropyridine. Nifedipine causes increase in heart rate, increase in contractility, and nifedipine has no effect on conduction. Nifedipine is rapidly acting dihydropyridine, and side effects of nifedipine are headache, flushing, ankle edema, hypotension, urinary retention, as nifedipine causes relaxation of urinary bladder, hyperglycemia, as nifedipine inhibits insulin release. So these are the common side effects of nifedipine: headache, flushing, ankle edema, hypotension, urinary retention, and hyperglycemia. Amlodipine. Another example of dihydropyridine is amlodipine. Amlodipine is longest acting dihydropyridine. It has slow onset of action, and reflex tachycardia in case of amlodipine is less. Side effects of amlodipine: headache and flushing are not present, but ankle edema is quite troublesome in case of amlodipine. Cardiac depressant effect, that is decrease in heart rate, decrease in conduction, and decrease in contractility. So in decreasing order, verapamil, diltiazem, nifedipine. Coronary vasodilator effect in decreasing order, nifedipine, verapamil, diltiazem. Peripheral vasodilator effect in decreasing order, nifedipine, verapamil, diltiazem. Calcium channel blockers are peripheral vasodilator, so they result in decrease in peripheral arterial resistance, and that causes decrease in afterload. Calcium channel blockers has no venodilation effect, so no decrease in preload is seen with calcium channel blockers. We will continue our discussion on drugs acting on angina pectoris in our next lecture.